Hi, thank you everyone for listening. This month is Taka's month on adulthood, so I'll be answering some questions pertaining to that. Okay, let's get started. The first question regarding aggression and anxiety is that puberty has brought on unmanageable aggression. What can help? So when we're looking at aggression specifically in the teen and adult years, the first thing I want to look at is constipation. It can be very difficult to discern constipation in an older child and adult because often you're not going to see the bowel movements. You're not going to assist them with potty training. And so oftentimes you don't necessarily know as a parent or guardian how often they're having bowel movements. So frequently, if you're having any kind of difficulty discerning that, we can order a KUB, which is basically an abdominal X-ray to check for fecal impaction. Bowel clean out can be very helpful for aggression. So typically we'll dose with, different kinds of magnesiums to clean out their bowels because severe impaction will definitely cause aggression in these children and adults. The second cause for aggression we will look for related to GI is gut dysbiosis. So we'll find that there can be Clostridia overgrowth, Candida or other kind of fungal overgrowth or other gram-negative bad bacterial overgrowth. And that can often cause anger and aggression. So if there's any other issues such as bloating, gas, or just intuition, clinical suspicion, we can order either a stool test or an organic acid test to check for some kind of bacteria or fungus that is out of whack. Definitely can be associated with aggression in these children. A third source I've actually seen recently and do see is wisdom teeth pain because around this kind of teenage years is when wisdom teeth will start to erupt and they may not necessarily be able to tell you. So clinical suspicion might be hitting their head or their jaw or any kind of wincing and pain. And so if you suspect at all it may be dental, you may want to talk to their dentist and go in for a consultation and see maybe their wisdom teeth are impacting or causing severe pain. And again, any kind of self-injurious, punching to the face would be a big clue. And another source of aggression that we see with kids and adults, older kids and adults, would be dietary infractions. When kids get older, I know my kids are aging into those teenage years. They go to school, they eat, gluten-free, or I'm sorry, they eat, gluten foods when they are currently gluten-free. They'll eat dairy, other kinds of, severe actual food allergies that's causing a lot of abdominal pain or reactions, inflammation in their gut or brain, and you don't necessarily know. So, sometimes it's just important to really take stock of what foods your children are eating now that they're becoming adults or they're away from the home. Another source of aggression may actually be hormonal imbalances. So it is important to look at a total picture, to get maybe a free and total testosterone. Studies are mixed with this kind of with regards to hormone levels in autism. Some show that there are increased androgens, while others say there are less. But nevertheless, a severe imbalance can trigger these kind of aggression. So you may want to talk to your doctor as well about looking into hormone investigation and possibly balancing. Another trigger that I frequently see in kids is that puberty can actually bring about EEG changes, basically seizure type activity. Sometimes it's just abnormal brain waves, or sometimes it can be actual true clinical seizures. So you do want to suspect if the child's complaining of any headaches, new attention issues, oftentimes maybe hitting their head, grabbing their head. There may be seizures or EEG changes. EEG is an electroencephalogram, which measures brain waves, electrical activity in the brain. Measure that to make sure that they're not having any new changes, even if it was normal pre-puberty, and oftentimes can be abnormal post-puberty. And then the last thing I would say to look for aggression causes is potentially social situations. This is not necessarily medical, but in the sense that, kids are out in the world, they're more independent, maybe, in their schooling settings. So we don't know if there's bullying or teacher issues involved. Maybe the staff doesn't know how to handle behaviors. They're not being treated in a way that best serves them. And so a lot of kids will get very anxious or angry at some kind of situation that is not, again, that is not serving them. So, in that situation, it may be prudent to even spend a day with your child at school, see what a typical day looks like. How are they handling behaviors that your child may be having? And ask other teachers or students what they're observing and if there are any other kind of situational triggers there. So the second question is that anxiety is suddenly out of control. We've avoided medication thus far. When should it be brought in, or what can we do? So this is a really good question. And it can be tricky. I mean, I think a lot of parents, especially in younger children, want to avoid medication, but there definitely is a time when it can be very appropriate. And at a certain point, perhaps a little sad or cruel to not treat if it becomes severe. So really, a lot of this is depending on severity. If there are kind of mild to moderate symptoms, we may look at certain supplements that can help with anxiety, such as magnesium, L-theanine, omega-3 fatty acids, taurine, lithium orotate can be helpful, 5-HTP. Um, but also, of course, too, you do want to look at underlying causes of anxiety. As I mentioned previously, and I'll also mention in the next question here. But just from a supplement standpoint, there are things that can help. However, if it's severe and there's things that are affecting daily life, such as they don't want to leave the house anymore, they're, engaging in self-injurious behaviors, they're hurting others, they do not want to go to school, so they're withdrawing from friends and family. Um, any kind of severe changes in diet, weight gain, weight loss due to anxiety. If it becomes an issue, then I would definitely consider starting medication. And there's certain medications that are more helpful and have been shown to be statistically significant for autism. So some of our favorites are propranolol, naltrexone, Namenda. I know some practitioners like to use SSRIs, so those antidepressants. And also, it is important to look at medications that may be helping with sleep, because often, if these kids are anxious and the anxiety is really high, they may not be sleeping, and anxiety might be compounding the issue. So, if you're anxious and not sleeping, then you're going to become further anxious because you're sleep deprived. So, things like clonidine or even trazodone are medications that can be helpful for autism, in a way that, can really benefit them due to decreased anxiety levels, better sleep. And again, there's also underlying causes, are there infections or are they hypomethylated? Maybe they have MTHFR and they're not detoxing properly or for a bunch of reasons, having detoxification issues. So always look for underlying causes and also mitochondrial support. So, mitochondrial dysfunction can also present as anxiety. So, giving things such as B vitamins, sulfation, so things like N-acetylcysteine, glutathione can help be very calming if there's too much oxidative stress. Carnitine and CoQ10 can also be helpful too. So and usually the reality is when we treat, we do a combination of both supplements and medications. Ideally, again, we'd find the root cause, but sometimes there's, we don't always find it, and medication can be very helpful in a very safe way that has been shown to actually improve outcomes with kids with autism and not just a band-aid. So, some medications like propranolol will help for anxiety, but also have been shown to help with speech and social interaction in addition. So, it's kind of a win-win situation. So please talk to your doctor about that, and don't be shy. Sometimes it's definitely needed and even kind to do so. Next question is, when is it PANDAS versus anxiety, and how would we know? So yeah, this is a good question. With anxiety, anxiety is common. I think most people have experienced some time in their life, and especially these preteen, teenage, young adults. People with autism can definitely experience it. PANS And just to back up, so PANS is an acronym, stands for Pediatric Acute Onset Neuropsychiatric Syndrome. Um, and PANS includes the diagnosis of PANDAS. So PANS is kind of a generic, kind of broad diagnosis, whereas PANDAS is specific for strep. So it stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with streptococcal infection. Um, and they can both present, PANS and PANDAS can present very similarly. And it's basically, considered a much more severe form of anxiety. And it has its own kind of subset of clinical presentation, a little different from your traditional just anxiety diagnosis, according to the DSM. So basically, what does that mean? PANS and PANDAS typically have an infectious trigger. So the infection can trigger antibodies that can often create a wide variety of inflammation in the body, including the brain. Um, and they can, like I said, they can have a similar presentation, both PANS and PANDAS. PANDAS is specifically triggered by group A streptococcal infection. So when you're looking for PANDAS, you can definitely get a blood test to look for anti-DNase and anti-streptolysin titers. So these are just basically strep antibodies in the blood. It's a very easy way to see, have they recently been exposed to strep? Are they ongoing carriers of strep in their body, producing these antibodies? So if it's positive, then you may also want to do a throat culture to see if it's actually growing in their throat. And that can be done by a traditional just pediatrician. And if both of those are negative, if there's negative strep in the blood from antibodies and in the throat culture, it's likely not PANDAS in origin. I have heard some people saying it can be, but in general, we would more consider a PANS diagnosis at that point. And so when we're looking at, PANDAS, there's usually a sudden onset, and it's often overnight. So the parents will say, I had a patient last week that they got exposed to something, and literally they woke up with these severe restricted eating. So restricted eating is very common, dietary changes, onset of new tics or severe OCD. Um, decrease in handwriting. So often the parents will say he was writing just fine, or his handwriting looked a certain way, and then the next day it changed. A new onset of tics and Tourette type symptoms. So like twitches or things that were not present before are now present. And a lot of times with PANDAS symptoms, that's what's called a sawtooth pattern. So it comes and goes. So it's relapsing and remitting kind of based on the day or even the week. So the child might have, or the adult aging child might have a horrible week, horrible day, severe OCD, and then it improves for a few days, and then it will come back, and so it goes back and forth. Fight or flight is often activated, and you can see autonomic response, the body's autonomic response to this. So oftentimes there'll be retracted eyelids, so eyelids that look very open and large. And also pupils may be dilated. So if you've ever looked at your child and saw those big, large, round, black pupils, that can also be a sign of inflammation or these antibodies that are triggering this kind of fight or flight response. So again, with anxiety, the difference, PANS, sudden onset associated with tics, OCD. Anxiety is usually less severe presentation. It's associated with less OCD and less tics in general. And there's usually more of a gradual onset with anxiety. Anxiety can, like I said, it may be situational. So, for example, if the child doesn't like to go to school, but when they're home, the behaviors kind of disappear. And like I said, if there's a person around that they don't like, but otherwise they're fine. Usually, that could be a sign of anxiety. Usually with kids, like I said, with OCD or PANDAS, it's very much out of their control, and it seems to be, kind of coming and going more based on infections and immune function than it is necessarily the immediate situation around them. So, and again, anxiety, as I mentioned, is less tick association. So that's a big clue. And less OCD, like severe tapping or opening, closing doors, having to have things in threes or lined up just so. Typically anxiety. doesn't have that feature. It can, but that leans more towards a PANDAS diagnosis. So how do we differentiate? What do we do about this? So the first thing, like I mentioned, you want to check for strep antibodies to see if it's strep. If it is, there's things you can do. Treating the infections, antibiotics can be very helpful. You can even do a tonsillectomy. There's some evidence in clinical trials to show that removing tonsils can prevent that reoccurrence because this bacteria can hang out in the tonsils exclusively. Um, and so that can be helpful. And then if there are, if it's PANS, if it's not a specific trigger to strep bacteria, um, finding the underlying cause can be helpful. So, for example, I do see kids with a lot of gut infections. Clostridia infections can trigger this kind of PANS syndrome. So looking at that, treating the Clostridia can be very helpful. Other literature shows that, Lyme can do this. I know some practitioners believe that mold can do this as well. So there's a lot of different infectious and viruses too. So a lot of different infectious origins. If you can treat the virus and or bacteria or fungus, um, then it can resolve almost overnight. And that is also a good indicator that it was in fact PANS or PANDAS. Um, Treatment options also can include anti-inflammatories. They can be very helpful. So what's called NSAIDs, non-steroidal anti-inflammatory drugs, um, if you give something like an ibuprofen, and for example, the behaviors improve, overnight or quickly, then that's another good indicator that it's PANS and not anxiety, just anxiety, because again, that inflammation in the brain is triggering antibodies, and if you can lower that inflammation, symptoms may improve. So anyway, NSAIDs, ibuprofen is a good drug to try. Corticosteroids, so things like prednisone, can be good things to try on a short-term basis. Possible antihistamines can be used, like Benadryl, if there's histamines involved. Um, and there's some evidence for IVIG, which is intravenous immunoglobulin. So some practitioners like to get what's called a Cunningham panel. And if those antibodies specifically to CAM kinase are elevated, you may want to consider IVIG. So again, all this workup is going to come from your doctor, but it is good to be informed and to know what your options are and really what you're looking for and when to seek medical help. Because these are very these are common diagnoses that we do see. And, again, it can be treated. And PANDAS, when you find it, and PANS, when you can treat it appropriately, the behaviors can resolve quite quickly. Okay, so the next topic we have is leucovorin calcium. Okay, so the next question is basically what is CFD? What treatments are involved, and what can we expect to see in terms of benefit? So I'm going to go into a little depth on this because this is a really popular topic and it is very important, and personally very near and dear to me and my family because, we've treated this in my own family. So cerebral folate deficiency is CFD. It's defined as any neuropsychiatric or developmental disorder characterized by a decrease in cerebral spinal fluid folate levels that in the presence of normal folate outside of the nervous system. So basically, it means low folate in the brain, but there's actual normal folate in the blood. So if you test the child for folate, it's going to be normal in the blood, but again, low in the brain. So a definitive diagnosis done for CFD would be via a lumbar puncture, and you would basically a procedure to look for the levels specifically in the cerebral spinal fluid. And there are some studies that do this, and they have actually analyzed children with autism and looked at their cerebral spinal fluid. Um, One cause of cerebral spinal fluid deficiency of folate, CFD, are antibodies to both binding and blocking folate receptors that interfere with the function of folate receptor alpha, and that stops the folate basically from crossing the blood-brain barrier. So essentially, the body can make antibodies. There's two kinds, binding and blocking, that prevent folate from getting into the brain. And when they looked at cerebral folate deficiency and autism, folate receptor antibodies, they said, accounted for about 83% of the cases. And mitochondrial dysfunction accounted for 43% of the cases of low folate in the cerebral spinal fluid. So essentially, in autism, you can have low folate in the brain, mostly from these antibodies, but it also can come from mitochondrial dysfunction, so that the folate has to be shuttled into the across the blood-brain barrier. So there are multiple causes of this in autism. Um, and I just like to have people know that even without these positive folate receptor antibodies, cerebral folate deficiency is possible in autism. Um, so a negative test doesn't mean that they have normal folate in the brain necessarily. Um, and just as a general prevalence, they found that in a meta-analysis of 21 studies looking at folate receptor antibodies in autism, they found that folate receptor antibodies are positive in about 71% of kids with autism. So in general, you can just, if you see a child, there's a 70% chance at least that they have these antibodies. If they have autism. And the meta-analysis also showed that children with autism were 19 times more likely to be positive for folate receptor antibodies than a typically developing child without an autism sibling. Um, so 19 times higher is pretty high. So it is a high prevalence specifically for autism. And so it's out there. This is a big deal and it's a big finding. And it could explain a lot of the symptoms related to autism and the comorbidities, such as repetitive behaviors and developmental delays. So what do we do about this? We know it's here. And cerebral folate deficiency can be treated with leucovorin. Now, leucovorin is a prescription medication. It's basically high dose folinic acid. It's an active form of folate. It's very important to know that it's not folic acid, Folic. It is not folic acid. So, folic acid is synthetic and it's in most vitamins and prenatal vitamins and in our food, and it's not going to be helpful. It's not indicated. It's not going to treat these antibodies. So you need an active form such as folinic. It is also different from methylfolate, which is also it can be a supplement. But typically that's not indicated as well because we need a high dose of folinic to cross into basically the blood-brain barrier via secondary type shuttle. So essentially, folinic is the treatment of choice to treat these antibodies. Most trials use a dose of anywhere from zero point 0.5 to 2.5 milligrams per kilogram per day of leucovorin. The most commonly used dose was 2 milligrams per kilogram per day. And then a lot of the newer studies were dosing 50 milligrams twice a day as kind of the higher ceiling dose. And when they're doing on these clinical trials with leucovorin and autism, the trials typically lasted 3 to 4 months in length. So they did find that it was not, a weekly trial. It did need to last at least 12 weeks in length. And there were a couple studies that reported that they needed 1 to 2 years of treatment to achieve the maximal effect. So again, normally when we put kids on leucovorin, it's going to take a few months to take effect, and you're going to want to leave the child on it for a year or two if it's tolerated well, to see if there's any further improvement. And in this meta-analysis of 21 studies looking at autism and cerebral folate deficiency, they found that leucovorin improved communication to a medium to large effect size. And what basically that means that there was a medium to large significance in improvement in both receptive language and expressive language. So communication in general was very helpful for. And it also had a large effect size on core autism symptoms such as attention and repetitive behaviors. So again, this was looking at 21 studies with autism and leucovorin. So the whole conglomeration of evidence shows that it is helpful for communication, attention, repetitive behaviors. And there's a study that showed that overall, if they had confirmed cerebral folate deficiency via lumbar puncture and autism, the meta-analysis showed that leucovorin helped with autism symptoms in 67% of children irritability in 58%, ataxia, 88%, pyramidal symptoms, 76%, movement disorders, and 47%, and epilepsy at 75%. So it can help, a lot of the comorbidity, the movement disorders, the coordination disorders, and even seizures. So again, if I have a child that has autism, and even in the aging, like we mentioned, the aging population, new onset of epilepsy, we may want to make sure that they're on leucovorin. Let's take a look at their folate receptor antibodies. This may help treat some of their seizures in an underlying cause type of way. So it can be very effective, and the studies look very promising. Folate receptor antibody positive children essentially may benefit from this medication. And without having to confirm, cerebral folate deficiency by lumbar puncture. So now when, working in an autism clinic where we treat autism, we're not going to want to get a lumbar puncture on everybody. It is invasive and there's risks involved. So given the safety, we often empirically start leucovorin if these antibodies are positive. And so it typically can be very effective in a lot of my patients. Um, so there's important things to know about this treatment as well. So there is an inverse correlation found between the higher folate receptor antibody titers and lower folate in the cerebral spinal fluid. So essentially, the higher the antibodies, the lower folate they found in the brain in two different studies. So there may be evidence that if the antibodies are higher, we want to dose them a little higher and maybe push that upper limit because they do have lower levels than other children with perhaps lower antibody levels. So you may want to talk to your doctor about dosing based on the severity or the level of antibodies. And a new study actually came out last year showed that MTHFR abnormalities may increase treatment efficacy. So if there's a child that has folate receptor antibodies, and there's MTHFR, those children might respond even better as well. And we know that that's highly prevalent in autism. So this leucovorin, this folinic acid, may actually be treating multiple problems in autism. So there's treating this MTHFR gene mutations and also treating antibodies. As a third way, may actually be helping with the mitochondrial dysfunction. So it can assist in healing in multiple different levels. Um, these antibodies are triggered primarily by cow's milk. Cow's milk will affect the production of folate receptor antibodies. The theory is that milk contains substantial amounts of folate receptors. And so when you drink milk, you drink these folate receptors. The idea is that I've heard from practitioners that if you have intestinal permeability, then these folate receptors from the milk will get into your blood and your blood will make folate receptor antibodies. So a milk-free diet has been reported to reduce folate receptor antibodies and can improve some symptoms with kids. So just removing milk may actually reduce these antibodies and reduce the need for leucovorin. But again, we often advocate for both. We should remove milk from the diet and try leucovorin and see how the child responds. In a trial, a 6-month dairy-free diet reduced folate receptor antibodies, and restarting milk actually increased these antibodies again. So again, it can be hard. I have a lot of patients. It's very doable, but refraining from dairy for 6 months was necessary to reduce the antibodies. And again, if there was infractions, then the antibodies may increase again. So the goal would be dairy-free, but also maybe in conjunction with a leucovorin trial, especially if the antibodies are positive. And then another study did find that folate receptor antibodies are intermittently positive in some individuals. So it's important to know that if you do a test and, do the folate receptor antibody test, and it's negative, that doesn't necessarily mean that it was never positive in the past or that it won't be positive in the future. So there is some evidence to suggest that you want to test it what they call on a longitudinal basis. So test it every few years, every couple years to see, is it continuing to be high or is it continuing to be negative? And that will help guide treatment as well. So keep that in mind. Also, blocking folate receptor antibodies are associated with reduced thyroid function. So if you test your child for these antibodies, they're positive for blocking. You may also want to make sure that you get a thyroid workup as well, because that can be correlated. And the last question regarding this is, what are the side effects? In a meta-analysis, there was, some adverse effects. Nothing is completely risk-free, but they were generally mild. The most common side effect we saw was excitement or agitation in 11%. So they get a little bit hyper or excited. Aggression was present in 9.5%. Insomnia in 8.5, headache in 4.9, and then increased tantrums in 6.2. So it can be activating for these kids. I do tell parents, to make sure that we have some calming supplements on board before we start it, to minimize side effects. Um, you know, Insomnia can be typically avoided in some kids if we dose it morning, the second dose in the afternoon. So first in the morning, second in the afternoon, as opposed to right before bed. And so, and then again, adding in things like magnesium and omega-3 can help calm children before we add this in, so that they have less side effects. But of course, too, you have to talk to your doctor if you're having any suspicions. I also do, when we prescribe it, we tend to start at a very low dose and titrate it up, increase it slowly over weeks. Um, because there was a study shown that side effects may drop off after about 9 weeks of treatment. So a lot of times kids will get hyper, and then they'll stay like that for 6 to 8, 9 weeks, and then the hyperactivity improves back to baseline. So if you can just increase it slowly, that may mitigate some of these side effects. And if you're having a hard time, I usually back off the dose to a lower dose that was previously tolerated well, and then just kind of ride that out for maybe 6, 8 weeks, and then try and increase it again from there. So there are ways to kind of look at these, but again, talk to your doctor. This is why it's good to have some guidance here. Um, and the next question is this treatment effective in the teen adult years as well? And absolutely. The answer is absolutely. Many children in the clinical trials with leucovorin were actually ages up to 15, 16 years old. So these studies included kids of all ages, even these young adults. So there's never really a too late age to start. Um, and again, just make sure that you're doing a decent trial of at least 3 to 4 months, and again, maybe even up to 1 to 2 years to see if you're going to have clinical improvement. And you do in these in the older children and young adults, you want to dose based on weight. So it's basically that means that they're going to need more leucovorin, a higher dose than a younger child would. So again, talk to your doctor about what dose might be appropriate. Um, and then the last question regarding leucovorin is how might it relate to PANS or PANDAS? And I think this is really interesting. This is a brand new study that just came out last year, 2024, by Wells, and it looked at 47 patients with a diagnosis of PANS or PANDAS specifically. And they found that 63% of PANDAS patients were found to have either blocking or binding antibodies, with the majority of them being positive for folate receptor antibodies, the binding antibodies. So specifically binding for PANDAS, almost. But it was surprising that ASD was associated with 0.76 lower binding titer. So autism kids actually had lower binding antibodies than the PANDAS kids did. And then the severe tics with PANDAS were associated with zero point 0.9 higher binding titer. So the tics, and so these PANDAS patients, which they're kids, but the age range was 6 to 18 years old, seemed to have higher binding, and they were associated with more tics. So it does seem to not just be exclusive to autism. And this can be, again, a cause of cerebral folate deficiency. And going back to the original definition, associated with neuropsychiatric syndromes. So that might include PANDAS. So essentially what this means is that if you have a child that has these symptoms of PANDAS, it's prudent to look at folate receptor antibodies in that situation as well, because that might be an important part of their treatment plan, treating underlying inflammation and infections, to resolve their symptoms. So So very interesting, and very important to note. Okay, so the last question is regarding GI and diet as a category. So the question is, when is it mitochondrial dysfunction and when is it poor diet? So it's kind of a tricky question, right? So the problem can basically be one of the chicken and the egg, right? Which one comes first, the chicken or the egg? So um, there's a lot of speculation here, but the short answer is both. We know that poor diet can cause mitochondrial dysfunction because there's forms of toxins that may be pesticides, metals, food dyes that can injure mitochondria. There's also nutrient deficiencies for poor diet, so they're not getting the, maybe amount of zinc or folate or fiber that they need. And also, in the opposite direction, mitochondrial dysfunction can cause poor diet due to issues with GI dysbiosis. So, to start, if you want to ensure that mitochondrial dysfunction is not contributing to GI issues, the first part is to address constipation. Because we know that basically if you have energy production issues, which is mitochondrial dysfunction, a lot of times motility will slow down and these kids will have severe constipation. And when motility stops in the gut, then you basically can have SIBO. So the stool will back up. You have bacterial overgrowth in your intestines. You can have abdominal pain from constipation, picky eating, food avoidance, literal, nausea, vomiting. And so these children don't want to eat because of the constipation downstream from mitochondrial dysfunction. So I like to start there when treating this because it's just um, it's an easy way to kind of assess, bowel movements, how quickly are or how frequently are they having them? Did we get an X-ray? Do we need an X-ray? But we can treat with supplements that may support the mitochondria and constipation. So, you can use magnesium, carnitine, vitamin C, omega-3. All these things can really help motility. There's a lot of patients that, sometimes they can use stimulant laxatives or suppositories, enemas, but basically getting their bowels moving will be very important. And that can help with, nutrient absorption, decreasing GI inflammation. Um, and so on the flip side, once you kind of get their bowels moving, it's important to optimize their health, optimize their diet, and support their metabolic needs. So, picky eating can be very difficult because, these children can often only want a few things at a time. So sometimes we just need to supplement with some of the basic needs that they need. For example, omega-3 is one of my favorites. So fish oil has been shown in studies to help with speech, social, eye contact, repetitive behaviors, attention, hyperactivity. So it is a food essentially, but you can give it as a supplement while you're trying to increase healthy fats in their diets. Um, and then there's also things, you can try and, insert fiber if that's what they need or things like that. If they're not eating fruits and vegetables, you can give some of these things as supplements. And it's also important to note that, good fats in your diet, something like coconut oil, I'm a big fan of. I recommend it a lot for cooking, and even for treatments because it has a lot of antimicrobial properties. It has, caprylic acid, and that can be antifungal, antimicrobial, and it's also a good source of energy for the mitochondria because it's a medium chain triglyceride. Some of it gets into the mitochondria without the carnitine shuttle. So it's a good source of energy. So sometimes optimizing diet in just a few subtle ways can help optimize mitochondria. And also eating quality fats, and I'm sorry, eating quality foods and decreasing toxins in the food might help. So typically when I'm advocating for kids, we want to do organic if we can. I know it's expensive and it can be hard to find depending on where you live, but in general, there are less things like pesticides and glyphosate in the food that can be very detrimental to their gut health and then their mitochondria downstream. So the next question is, when is it ARFID, it's a ARFID, avoidant restrictive food intake disorder, or just picky eating? And are they one and the same? Um, So basically, ARFID is a diagnosis, that does not have an origin. It's kind of a non-specific diagnosis. Um, so while picky eating often